Basically, this session we are starting. This is basically for diabetic retinopathy. On one hand, we will be talking about diabetic retinopathy, various aspects like macular edema, what are the clinical steps, what are the other features. And on the other hand, we will be talking about the human analog. So this has been crafted in such a manner. I want to go to the next slide. Yeah. So basically, we will be listening to Dr. Avijat, who will be sharing his what has been our previous experience. We have been working on this human analog for almost now 5 years. Dr. Rajiv will be talking about screening strategies. What is the current role of AI? Then there will be Dr. Ajay Didani correlating investigations. Chawla sir will present on DME management in a case-based scenario. Dr. Luthra will be talking about intravitreal. They will be joining us. Lasers in DME by Dr. Vinita. And then Professor KJ Singh will have his final word. This is what we call as human analog. Now, what is human analog? It is getting the things done by human resource what we want a computer to do. So what we want a software to do, if we are getting it done by human beings, that is the human analog. In artificial intelligence, basically what we do, we use picture, we divide into arithmetic expressions, and then we reform a picture. So a picture, a dog is recognized as a dog or a fish or a cat. So computer will be able to identify a normal retina or a diseased retina. Basically, AI remains a screening tool, and the purpose is to identify treatable diabetic retinopathy. And now it has been extended to prognosticate various aspects of the disease. What we need to understand is that human analog, like AI, is also primarily a screening tool only. When we teach our students, we teach them in a very complicated way. We teach them so many classifications. We give them, but when we talk about computer, we give them a very simplified picture, which is very easy to identify. So if we can get such simplified things as we tend to occur as we understand in the natural course of disease, then things will become very easy for our HR to identify. So this is the IDX platform, which uses this criteria, which is known as MTM diabetic retinopathy. If your picture is matching with this picture, you will refer it to an eye care professional. If it is negative, the AI will say that you come after 12 months. And this gives you a 90% sensitivity or specificity. But they are using a criteria which is level 35 or higher of the ETDRS chart. So basically what we understand is that AI is based on picture recognition and interpretation. In this presentation, which has come in February 23 only, what we understand is that when we are interpreting a picture, manual interpretation is as good as a computer generated interpretation as far as image identification is concerned. So what is human analog? A human analog should have a simplified identification criteria, an easy to handle tool, a simplified achievable target, and if we have this much, then our outcomes will be predictable. So what we are doing in AI, we are simplifying it, we are standardizing it, and then we are reaching to a high sensitivity. If we do the same thing for human thing, then our results will be equally good. So we have decided, earlier we decided that we will use VTDR as our referral point. So in VTDR, as we know, there is a 4-to-1 rule. There is either we have neovascularization or we have preretinal hemorrhage, vitreous hemorrhage, or macula involving center or not involving center near. So these are the features of VTDR which we were using for identification. But if we use VTDR as a reference threshold, then the sensitivity is moderate. Although our referrals are more specific, specificity is high. And referrals will be more appropriate. But we need higher level of training in identification because things like IRMA and beading are very difficult to identify. So we need to relax the referral criteria. So what has been done in various AI modules, they have used this ETDR as a scale which matches. So this is more than mild diabetic retinopathy and this is the VTDR thing. And what they are using is more than mild diabetic retinopathy as their referral feature. So if we relax our feature from VTDR to MTDR, then our pick rate will become very easy. Our training will become very easy also. What has been shown that if we do a screening of diabetic retinopathy, then preventable blindness or the blindness induced problems will go down significantly. In 2020, interestingly, WHO guidelines have come for screening, and what they are saying is very interesting. They are saying, WHO is telling that screening can be carried out by family doctors, optometrists, ophthalmologists, physician, endocrinologists, internists, residents. So they have not left anybody. And what these human resource should do, they should be trained to examine the eye. Either they should be trained to examine the eye, and if it is difficult, then they should be able to interpret a picture. So that is what is WHO guideline in 2020. That is precisely what we are saying, but we are saying it from now to 2017-18. And that is what we call as human analog. Recently in 21, Rajiv Raman has come out with a famous article in IGO, and it has certain points. And the point which I took it out of it, that there is a need to strike a balance between what is universal or what is ideal and what should be done. For example, if we screen the whole population, that is ideal. But if we screen only the diabetic clinics, then that should be good enough. So where we are, we understand that preventable diabetic blindness is a significant challenge in India. Screening activities reduce the incidence of visual loss. That is what the European experience has also said, and that is what the WHO report also says. VTDR we took as the standard threshold for referral, and now we have reduced it to MTMDR. So we are using the same criteria for human resource training, what they are using for AI. So in order to evolve the AI thing, what has been done, the disease has been simplified, the classification has been simplified, and the criteria has also been simplified. So for sake, we are using MTDR, that's a good alternative criteria for referral threshold. And human analog, therefore, is an important tool to handle the wrath of preventable blindness, especially in our context where human resources in plenty. It's also a viable standard alternative to diabetic retinopathy.